Okay, Mila, how you been?
I've been good. I got a little sick, but I hope it's not too evident.
Well, I can study even if I'm sick. I'm sure you're the same way, right? If you're in bed,
Yeah,
you read probably, right?
yeah, I do.
I
I
think
was
most,
busy compiling the lecture for today, so inshallah, let's see how it goes.
yeah, you're not like a normal sick person that just stays in bed and doesn't do
No,
anything.
no, there was a lot to do. We
Well, the
also have
internet makes
assignments
that
to
better. If
submit.
you're in bed, incapacitated in bed, you got the internet. I mean, I'm probably like you. I could be anywhere. If I have access to the internet, it's great. No matter where I could be lying at the bank or stuck somewhere in a doctor's office. It's great. I said, no problem. I'll wait an hour. So what? I'm on the internet.
Yes.
You're the same way, right?
Yes. And
Yeah.
actually, like I did mention it before, right? Like we have different like cycles. So this one we had to like give an exam. I just gave an exam like a few days ago. We had to submit an abstract. We have to like go and write assignments. So it's all very busy. There's no time for like resting. But oh well.
No, it's a good part of your life. And that's a part of life I don't want to leave. And you won't leave it either. I mean, I don't think you're going to wake up one day and say, well, I'm not interested in neurosurgery anymore. Yeah, it's just something that's going to be there for the. I mean, it's good for when you're my age. I mean, man, it's great, great. I'm not retiring. Are you kidding? This is one of the best times of my life. And
Yeah,
as
that's true.
far as medicine, it's I don't know. Maybe it's not the novelty either because I've been doing it for like almost 10 years. It's not
Wow.
the novelty because it's still every day. I mean, it's something new.
Yeah, that's true.
And the looks for the information junkie, it looks very good.
Yeah.
Okay, we'll start on time. We'll wait a few.
Yes.
We'll wait. If you want to wait a few minutes.
Actually, I'll just start in a minute.
Yeah, yeah, okay, that's no problem. Yeah, that's fine. That's fine. That's fine. Okay, 1 minute. Okay. Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from beautiful Miami Beach, home of Neurosurgical TV. We have another episode of Neurosurgery Basics run by Mila Mangi. She's from Saudi and she's now in Russia doing her residency in neurosurgery. She's enthusiastic. She came to me and said, "Hey, I want to do some webcast on basic stuff for the medical student that knows that neurosurgery is in their path, as well as young neurosurgeons." So welcome, Mila. It's all yours.
Thank you so much, Dr. John. So today, one of my topics is the revision of some important topics like encephalitis, Parkinson's, and we have some brain tumors. I'll be sharing my screen now. All right. Can you guys see my screen?
Yes.
Yeah.
All right. So, first of all, um, what is encephalitis? As medical students and as clinical residents, you have to know the definition. It is an acute inflammation of the cells in the brain due to infection. Now, when we hear the term infection, what kind of causes do you think come to your brain? Well, you can have viral causes, bacterial causes, and protozoal causes as well. First, viral causes. What is it caused by? Well, you have to think about different types of viruses since it's viral. Rabies virus, herpes simplex, Epstein-Barr virus, or arboviruses. It could be the direct effect of acute infection or as a sequelae of a latent infection. Again, a very important definition you have to remember. It's not just people getting acute infections. No, they can have latent infections, and as a result of those latent infections, it can further develop. Next, bacterial causes. We have syphilis, we have mycoplasma. Moving on towards protozoal causes, you have toxoplasmosis, plasmodium, amoeba. Next, types of encephalitis. We have a few types. For example, you can have the infective encephalitis. Now, the term infective encephalitis, even if you don't know all of it, just try to focus on the word. Infective means caused by bacteria, viruses, and some protozoa as well. Limbic encephalitis, autoimmune encephalitis. Autoimmune, I'm sure everyone knows this term, is that when the body fights against its own organisms. Next, we have encephalitis lethargica. Moving on, let's talk about the prevalence. Well, which type of people get affected with encephalitis? Well, it's common in older adults. And all right, it's common in older adults and children under the age of 1. Also, people who have a weak immune system. People who have weak immunity are more prone to getting attacked by opportunistic infections. Next, we're going to look at some clinical features. Now, as you can see on the left side, can you guys see my cursor on the
Yes.
screen?
Yes, we
Yes,
can.
yes.
All right. So we have the cerebrum. Okay, what kind of causes or what kind of things can we see in patients? Well, coma, confusion, dysphagia, involuntary movements, seizures, hemiparesis, which basically means half side of the body is paralyzed. And moving towards the midbrain, you can see the arrows. Midbrain, cerebellum, brainstem, and spinal cord. Each one of them, you can have different sorts of problems, like for example, dysarthria in the cerebellum. Patients can also come with some of these clinical complaints: a fever, your common headaches, vomiting, and let's say irritability. So whenever a patient comes in with these types of clinical symptoms, try to think about the differential diagnosis. First, as a medical student or even as a clinical resident, try to come up with not just one diagnosis. No, you should have a wide knowledge about the different sorts of differential diagnosis. Once you have your differential diagnosis, then it's easy to move towards the diagnosis. How do we diagnose encephalitis? Well, basically, first of all, we look at the CSF analysis. We can find that the WBCs have increased, protein increased, glucose is increased. Doctors can also tell patients to go for a brain CT scan, an MRI, and in ECG. A complete blood picture is important to see what kind of components are affected and to what extent. Also, a brain biopsy, just to make sure of our findings. Treatment. Oh, wait. Okay. Yeah, once we have the diagnosis, you can move towards the differential diagnosis. So sometimes students get confused by differential diagnosis. Some even question, why do we even need differential diagnosis? No, it's so that if a doctor comes and asks you, okay, so why does this patient have encephalitis and why can't it be cerebral abscess or brain tumor, you should be able to solve some of these common questions. The only way to do that is through practice and through reading about every disease and making diagrams, whatever suits you. Treatment. Well, patients mostly they're advised to have rest, a lukewarm sponge bath, mechanical ventilation, and IV fluids. Medication. All right, the medication is actually divided into like a few groups. For example, we have the antiviral medication, we have antibiotics, we have anticonvulsants, we have acetaminophen to reduce the high-grade fever. All of these depends on like how severe the person is infected with encephalitis. All right, please just excuse me. All right, yeah, Dr. Johnson is here. Okay, no problem. Okay. Moving on towards the complications now. If encephalitis is not treated early, if encephalitis is progressed, patients can die with epilepsy, brain damage, skin rashes. They can also die like sudden deaths as well if it's not treated. Okay. Next, the spinal cord injury, another very important topic for all medical students and clinical residents, especially in their first year of residency in neurosurgery. If you do not know spinal cord injuries, it's really going to be difficult for you to understand why patients come in with certain symptoms and how do doctors identify the signs. So let's begin. Spinal cord injury is damage or trauma to the spinal cord that results in the loss of impaired function of muscle, sensory loss, or autonomic dysfunctions. Now, the diagram here, this is the dorsal side and this is the ventral side. This is the lateral horn and this is the ventral horn. Can you guys see my cursor?
Yes.
All right.
Yes.
You have the central canal here. We have the gray matter and the dorsal horn right over there. And this is, of course, the white matter. This is the basic picture of the spinal cord. You know, you can draw it up, label it however you want, stick sticky notes on it, whatever helps you remember. Just in case, you know, you're expected to like give proper answers, if you're expected to like perform an exam and, you know, there's a diagram there. And if, for example, you forget something, you should have it written down somewhere in your notes just so it's easy to revise. Moving on towards the etiology. The etiology of the spinal cord injury. Well, patients can come with fractures or fractures with dislocations. Many patients suffer sports injuries or different types of injuries. For example, like I had once a patient come in, he had an injury at the gym. He was stretching, picking up some weights, heavy weightlifting, and boom, his spinal cord muscles, one of his muscles was injured, and he didn't know what to do. He was running from doctor to doctor, clinic to clinic until, you know, he came to the hospital and, you know, he's like, I have this problem. And when I took his history, I understood that this was caused by a sports injury. You can also have stab injuries or gunshot injuries. All of these can lead to spinal cord injuries. Surgical procedures. Surgeries done in and around the spinal cord can damage as well. A lot of students sometimes forget that even surgical procedures are not 100% safe. Some of them can have adverse effects, and it's just good to like remember all of your terms. Let's move towards the epidemiology. We have the prevalence of the spinal cord injury. For example, let's talk about India. It's 1.85 to 2.19%. Usually occurs in adults between 20 to 40 years of age. It's more common in males as compared to females. A lot of people, this is the most common cause. Okay, this is a very famous, let's see, a best choice question, and even it's an MCQ question in many exams. What is the most common cause of the spinal cord injury? A lot of people get this wrong, so please try to like remember it. Fall from like a heighted area is the most common cause of a traumatic spinal cord injury. Here we can see a little diagram. 50% is the cervical injuries that patients can suffer. Next is the thoracic injuries, which is second most common. cause. Second most common area where, the spinal cord is affected is the thoracic. And lastly, it's the lumbosacral, which is only 15%. Also comes up in a lot of exams. Moving towards the classification. Okay, the classification is based on an Asia impairment scale. We have four sorts of, let's say, components. Asia A, Asia B, Asia C, and Asia D. It's important to understand why we need classifications, what is the importance of classification, and try to understand what is the difference between, let's say, a complete and an incomplete Asia C classification. If we look at Asia A, which is complete, it is basically no motor or sensory function is preserved in the sacral segments. And the sacral segments are between S4 to S5. Let's move towards the Asia B, which is the incomplete. Sensory but not motor function is preserved below the neurological level and includes the sacral segments S4 to S5. So this is pretty straightforward. I don't really need to go into depth with it. Next, Asia C incomplete. Motor function is preserved below the neurological level, and more than half of key muscles below the neurological level have a muscle grade less than 3. It's also fairly simple. This has a specific grading. Try to remember it, grade less than 3. Lastly, Asia D, incomplete. Motor function is preserved below the neurological level and has at least half of key muscles below grade 3 or more. So this is another sort of number you have to try to remember. Asia E, this is normal. Motor and sensory functions are normal. So this is the Asia impairment scale. Now, neurological level. Why is this written in a block? Well, let's look at it. It is the lowest segment of the spinal cord with normal sensory and motor functions in both sides of the body. This is a specific test. It's called the neurological level. Number 2, we have another sort of classification as well. It always comes up in exams, no matter what kind of exam you're trying to prepare for. So please be very careful when you study each one of these classifications and syndromes. First of all, we have the anterior cord syndrome, posterior cord syndrome, Brown-Séquard syndrome, central cord syndrome, the conus medullare syndrome, and the cauda equina syndrome, which is personally my favorite. Let's start with the anterior cord syndrome. Anterior. Basically, it describes the damage to the spinothalamic tract and the corticospinal tract. There is a complete motor loss below the spinal level of lesion due to the involvement of the corticospinal tract, because, as I just mentioned in the definition, damage to not only the spinothalamic but the corticospinal tract as well. There is what kind of complaints did the patient come with? There's a loss of pain and temperature at and below the level of the lesion due to involvement of lateral spinothalamic tract. Preservation of position. This is a function which is preserved. Vibration and touch nerve. Okay. This was the basic information about the anterior cord syndrome. Posterior cord syndrome. It describes damage to the dorsal column, loss of position, vibration, and the touch nerves. Preservation of the motor function. Now see, this is a little different. Preservation of motor function, pain, and temperature. As you can see in the diagram below, this is shaded. This is the posterior cord syndrome. Moving towards the Brown-Séquard syndrome. This is a rare form. I've heard a lot of students say that, if it's rare, why do we even bother studying it? It's a rare thing, it's not going to come up in exams. But it does. Unfortunately, it does. So you have to know this really well. It is a rare form of incomplete spinal cord injury, characterized by damage to one side of the spinal cord, as you can see in this picture of this cartoon. Half of the spinal cord is damaged. It accounts for about 4% of all traumatic spinal cord injuries. Again, it's a very rare disorder, but that doesn't mean that it doesn't happen. No, it still does occur. What do patients come in with? What kind of signs do we see? Loss of sense of vibration, deep touch or pressure, proprioception, and motor functions below the level of the spinal cord injury at the same side. Okay, so this is like a layman's term you can like use on the same side, but the medical term is ipsilateral. Try to like remember it if you don't know it. Loss of sense of light touch, pain and temperature on the opposite side of the body, contralateral. So we have different sorts of like things that you need to remember. And when you like write notes, when you like try to like draw like let's say cartoon figures or illustrations, it's easy to differentiate between like what kind of symptoms are going to be in the ipsilateral side and what kind of symptoms are going to be in the contralateral side. Individuals with Brown-Sequard syndrome typically achieve good functional results during inpatient rehabilitation. So that is one thing that as medical students, as clinical residents, we have to like try to understand. The rehabilitation is like important for patients, especially with Brown-Sequard syndrome. Next up, we have the central cord syndrome. It's the most common type of incomplete spinal cord injuries. It is the resultant of the contusion of the central position of the cord. Again, we have a small little diagram just to show you an idea of what it like appears as clinically. Upper limbs are more affected than the lower limbs. Motor dysfunction is more affected than the sensory loss. Next up, we have the conus medullaris syndrome. It's caused by injury to the conus medullaris and the lumbar nerve roots. Injuries at the level of T12 to L2 vertebrae are more likely to result in this syndrome. So even though it affects the lumbar nerve roots, which one does it affect the most? Try to remember it's between L12 to T12, to L2. Last but not least, my favorite syndrome is the cauda equina syndrome. It is caused by injury to the cauda equina position of the spinal cord. It is an extramedullary lesion. There will be sensory loss and motor dysfunction more in the digital lower limbs than in the proximal area. Another thing which you have to like remember. In the intramedullary lesions, there will be sensory loss and motor dysfunction more in the proximal than in the distal lower limbs. These two things come up a lot in MCQs, they come up on a lot of exams, and sometimes they have the wordings changed. So whenever you're trying to solve questions, try to like write everything down so that you don't make a mistake and lose easy marks. If we focus on clinical features, what do we see? Let's see. In this, patients come up with spinal shock. Spinal shock is it's following as the most immediate thing that follows after an acute injury to the spinal cord. Okay. Next, we have the basic definition of spinal shock. It is a state, if I can move it. Oh, sorry. Where did it go?
Lost in a smartphone.
No, I'm using my laptop.
Oh, okay.
Okay, we're here. I was just trying to like move. Okay. Spinal shock. Spinal shock is a state of, it is characterized by the loss of tone, loss of reflexes, and total inactivity. After the stage of spinal shock has passed, the various neurological defects start manifesting. For example, we have the motor and sensory impairments. We also have autonomic dyslexia. We also have the impaired temperature control. For example, after damage to the spinal cord, the hypothalamus can no longer control the cutaneous blood flow or the sweating. Patients also lose the ability to shiver below the level of the lesion. Hypothermia may occur, and hyperthermia occurs more likely later on after the injury. We as clinical residents, we also see most patients fall into respiratory dysfunction. A lot of them have spasticity. A lot of them have sexual dysfunctions, bowel and bladder dysfunctions. And if we talk about the bowel dysfunction, this is one of the most common features seen in patients with the cerebral spinal cord injuries. So this is another common question out of all the important features, which is the most common. You can easily tick it, it's bowel dysfunction. Next, even with the bowel dysfunctions, like we have like three important types of bladders that you have to like try to remember. We have the atonic bladder, the autonomic bladder, and the autonomous bladder. So when you like try to like focus on these types of things, it's easier to solve questions and not get confused by them. If we look at how do we manage the bladder management in like hospitals and private clinics, well, a lot of patients go through the intermittent catheterization. They also have the suprapubic tapping. This is like the management in a list in a series. The third one is the Valsalva maneuver. We also have the surgical injection of suprapubic catheter and the condom catheters. Number two, patients can also have, like, as I just mentioned earlier, bowel dysfunctions. And for bowel movements as well, we have like specific classification that we do follow. For example, let's say for people with a reflex bowel, what do we use? We use suppositories and we use digital stimulation techniques to cause the defecation. There are different sorts of techniques that doctors use in clinical settings to help patients with their symptoms. Moving on towards complications. If the patient's condition is not diagnosed correctly and is not diagnosed early, a lot of complications can occur. For example, we can have DVT, pressure sores, we can have different types of pain. For example, we have the neuropathic pain, we have nociceptive pain. Patients can also have osteoporosis and ectopic ossification, all of which are very important and dangerous complications if not treated earlier. For the diagnosis, we have the complete blood count. We also need to check about the ABG analysis, X-rays, MRI, CT scans, all very important. And as I previously mentioned in my previous lecture, that you have to understand the differences between why we follow like different sorts of strategies. What is the difference? Emergency management. Now, if you're like sitting on your 24-hour duty and suddenly, they ask you what is emergency management, you have to avoid both active and passive movements of the spine when the spinal cord injury is suspected. Initial treatment focuses on preventing the damage and preventing further damage and resuscitation. Immobilization, hard cervical collar, and cervical spine injuries. Many doctors will advise patients to like do this just to help alleviate their symptoms. Patients are also resuscitated to maintain airways, again, very important. And once we maintain the airways, it's important to like focus on different types of managements. For example, we have the conservative management we need to discuss before just moving to the surgical management. I've had a lot of students even ask me, like, why do we even need to move towards the surgical management? Like, why can't we just like get done with the conservative and that's it? No, it's not like that. Everything has a method. If you understand the conservative management, then you can also understand that some surgical management is important, for example, in different types of conditions. For example, let's say a patient comes in and the surgery is indicated in the spinal cord if the spinal cord is compressed and the spine requires stabilization. In this kind of condition, conservative treatment is not going to help. You will have to have one of these surgical procedures, for example, surgical decompression, a spinal fusion, discectomy, a laminectomy as well, or an artificial disc implantation, which can be expensive in some places, but again, doctors will advise patients or whatever is best for them. How to manage the patient. There are specific goals that as students you have to like try to understand. You will be asked this a lot in Vivas. For example, like what can we do? We have to maintain or achieve proper positioning of the patient, maintain chest conditioning, integrate the sensory senses to encourage early strengthening of the weak muscles, to educate skincare to the family members, and obviously to also like regain bowel and bladder problems. Next, we also have some important goals further. For example, to maintain joint, for example, to maintain deformities, to maintain the airways, to maintain a sensory hearing, to increase strength, and to regain the bowel and bladder problems. These are also like other things which when I send you the PDF, you can like go through like in each type of week what kind of specific treatment we can like focus more before, of course, moving towards the surgical treatments. Next up, we have the Parkinson's disease. I don't know why, but the diagram isn't very clear. Maybe if I can like take another picture, I'll like send it over onto the group. Um, Parkinson's disease. I'm sure everyone knows that this is a very common neurological disease that a lot of students always get asked about, no matter where you are in the world, no matter what you're doing, what you're studying. It's very important to understand what exactly is Parkinson's disease. It is a slowly progressive disease involving the degeneration of cells in the basal ganglia and the substantia nigra, leading to a fall in dopamine levels. Simple definitions, if you just like try to understand the method, try to understand what is being affected, it's easy to like move towards etiology, causes, symptoms, and treatment. Dopamine is a neurotransmitter produced at the ventral segmental area. Next up, we have the etiology. Parkinson's can be idiopathic. It can also be caused through chemical toxicity, through some drugs, for example, a phenothiazine. We can also have metabolic causes, for example, abnormal calcium metabolism, or it can be secondary to Alzheimer's disease. Epidemiology. Parkinson's disease is the second most common neurodegenerative disorder. These are also important definitions, very simple, but students make a lot of mistake with sometimes the onset or which it affects more. For example, the onset is between 50 to 65 years and affects males more than females. We have the pathophysiology right here. There's the direct pathway and then there's the indirect pathway. You can see the cortex over there, the striatum, the substantia nigra, movement of dopamine, and we have the thalamus over here. Now, in normal individuals, we have the excitatory output and we have the inhibitory output. And dopamine, when it binds to D1, it stimulates the direct pathway. When it binds to D2, it inhibits the indirect pathway. Now, this was in normal individuals. Now we look at in Parkinson's disease. We have the degeneration of the whole nigrostriatal tract. It's not there. It's degenerated. What happens? Clinical features. We have specific cardinal signs of Parkinson's disease, which you have to know. Patients always come in with a resting tremor. They can also have rigidity, bradykinesia. They can also have a pill rolling tremor. It is a very common question and it always comes up. Pill rolling tremors are between the thumb and the index finger. Patients mostly do have slow speech, a stroked posture. They can also come in with excessive salivation and depression. Kyphosis is also a common condition and a fenestrating gait. It's also called a shuffling gait. It's a specific type of gait that patients with Parkinson's disease come in with. These are all the other things which I have written down just to like try to make it easier for students when they're revising, like let's say the definition of like dysarthria or hypoaphonia, what kind of speech defect is there. Now, some other cardinal features or some extra features which patients do have. They can have dementia with Lewy bodies, okay? They can also have a progressive supranuclear palsy. Just some things that, these are just some extra features. For example, like if you have an oral exam and, you like want to try to like take it one step further. So if you mention some of these points, you can perform really well. Moving towards the complications, we can have ankle swelling, nystagmus, muscle atrophy, since we just discussed that there is a degeneration of the tract, so leading to muscle atrophy. Vertigos, imbalance, hallucinations, weight loss, these are all common complications. We also have a specific scale. It's called the modified Hoyne and Yan scale. This is to grade the progression of the disease. Most diseases, they have a specific scale on how to like grade them. So like for Parkinson's, we have this scale. Basically, it's also just numbered, just like, for example, if I compare it to the Glasgow Coma scale, which measures like, the eye movement, measures the motor movement, and also measures like speech. Same thing. Literally the same thing, comes with numbers and like what does the number stand for. Moving towards investigations, we have our routine blood investigations. We also have the transcranial ultrasound, and we have the MRI. The reason why we have an MRI is to show the degeneration of neurons of the pathway. Like MRI is going to be our best method to diagnose Parkinson's disease. Management, common drug, we give the levodopa. Also, we can also give them dopaminic agonists, we can give them anticholinergic substances as well. And if the if the conservative management isn't working, then we move towards the surgical management, which basically we can have like the deep brain stimulation surgery. A lot of people do complain about like um why do we even need like different sorts of surgeries and what is the importance? Each surgery has its own indications, has its complications, sometimes can have its own benefits, and we have to differentiate between different sorts of patients, let's say for their age groups. Maybe they have comorbid infections, and which the doctor is going to tell them exactly which treatment is the best for them. Now, if we move towards, okay, this is some things which I had just written as examples. Yeah, if we move towards the neurological examinations, we have different sorts of examinations, as you can see here. First, we have the higher mental function assessment. Neurosurgeons, early clinical residents in neurosurgery have to understand the neurological examination for patients. You have to test for the mental function assessment first. Next, cranial nerve examinations. We have 12 cranial nerves, and there are specific tests that you can do to examine them each. We have the sensory examination, upper extremities, lower extremities, which sides are affected more as compared to which sides are affected less. We also have the combined cortical examination, and then, of course, your reflexes. You have your superficial reflexes and then your deep tendon reflexes. Last but not least, you can check for the posture of the patient, gait. There are specific gaits in different diseases. For example, like shuffling gait is typical to Parkinson's. And lastly, we have the balance and coordination. It is mostly affected. And this is the coordination test, as you can see over here in different patients. Like this is an important test to be taken. Functional assessment, this is done through a specific index, and it has a specific score as well, and you can calculate it in different patients. Investigations. Now, once you have established your diagnosis, which is Parkinson's, you move on to your management. What is your goal in your conservative management? You have to maintain the joint mobility. Try to reduce the rigidity of the patient's muscles. Try to reduce weakness and improve the physical fitness, overall general health of the patient. These are all your intended goals. Improve balance, coordination, normalize the gait pattern, because obviously shuffling gait, it's not a normal gait. It is an abnormal gait. And if there are methods to like try to improve it, you have to go for them. And to improve the strength of the patient. These are all specific things that you can like look into and how to improve each sort of condition. It's not really required to like know exactly all the details, but just for your information, you can like go over this PDF and like try to understand it better. Moving towards brain and spinal cord tumors. Tumors, how can you define a tumor? Well, basic definition. Tumors can be defined as an abnormal growth of tissue resulting from uncontrolled multiplication of cells. Very straightforward, no surprises there. We have the epidemiology. Primary brain tumors, primary spinal cord tumors, we have a ratio 20:1 in children and 5:1 in adults. Younger individuals are affected more than the adults. We also have two different types of things that we need to focus on, the supratentorial and the infratentorial. You can see both diagrams in adults. The tumors which are more affected, which are more caused, are like in the supratentorial, as compared to children. Most tumors they lie below the tentorium. Next, we have the etiology. We have specific risk factors that we need to consider. For example, the age of the patient, gender, family history. Are they exposed to any infections like the Epstein-Barr virus? Are they exposed to any radiation? Have they had any exposure to formaldehyde, any other compounds, any other agents like vinyl chloride? All of these are important etiological factors that, as clinical residents, you have to ask the patient during history taking. Classification of brain tumors. Well, this is a very common question. It always comes up. If we classify brain tumors on the nature of the tumor, we have two groups, benign and malignant. Benign, simple definition, slow growing, it's capsulated, does not metastasize, and it's well differentiated. Whereas malignant, as the term indicates, is fast growing, non-capsulated, it metastasizes, and it's poorly differentiated. If we want to classify brain tumors on their origin, we have primary tumors and we have secondary tumors, intracerebral tumors, and then the tumors arising from abscesses from supporting structures. If we focus on primary brain tumors firstly, these tumors result from abnormal growth of brain that originate abnormal growth of brain cells that originate in the brain. Most of the primary tumors are benign in type. Another important question that you have to try to like remember. We have the intracerebral tumors. They're also called gliomas. The most common primary benign tumor are glioma. This is a very important best choice question, mostly comes up. They are divided into, so this is a classification of gliomas. You have the astrocytoma, glioblastoma, ependymoma, medulloblastoma, and the oligodendroglioma. Moving towards the second part of the classification over here, we have the tumors arising from supporting structures. For example, meningioma, a schwannoma, craniopharyngioma, a germ cell tumor, pineal region tumor, and the pituitary adenoma. If we want to classify the spinal cord tumors on like basis of intradural or extradural, if we move towards the intradural, we have the intramedullary 5% and extramedullary 40%. And the extradural tumors are 55%, mostly metastasizing. Now, if we go towards the clinical features, okay, this is just a picture. Try to show you like extramedullary tumors, where do they occur, and then the intramedullary tumors, where is like the location, and this is the dura mater. Clinical features. We have for the brain tumors, symptoms usually develop slowly and worsen as the tumor grows. Fairly simple and easy to remember. Most common symptom, headache. Seizures can be demonstrated as convulsive and loss of consciousness or bladder control. Patients can also have change in personality. Some patients even reportedly can have psychotic episodes. Episodes, either the patient themselves will like tell you that, I had this episode, or a family member is going to give you this history. Blurred or double vision, tinnitus, nystagmus, loss of balance, all of these are clinical features that can come up in brain tumors. If we look at spinal cord tumors and what kind of conditions, what kind of symptoms patients have, they can have sensory problems, numbness. They'll complain to you, they'll tell you, I can't feel this, or I can't feel that, I have pain here. Loss of motor control, loss of reflexes, gait disturbances, muscle wasting. Another common classification of clinical features in spinal cord tumors. Moving towards the diagnosis. I have to stress this, I cannot stress this enough. If you do not have a proper history and if you do not know how to take a detailed clinical history, you will not get your diagnosis correct. And if your diagnosis is not correct, you're going to mess up your differential diagnosis. So basically, first step is your clinical history. Ask important questions, ask open-ended questions, ask all of your things that are noted in this PDF. This PDF has most things that, will help you not try to make simple mistakes. Once you have established your clinical history, then you can move towards the neurological examination. After the neurological examination is done, you can ask for the MRI scan. So this is all like systematic. After you have this MRI scan to give you a clearer picture, you might be able to ask the patient either to go for a CT scan, for example, if the MRI isn't advisable, or they can even go for the PET scan, position emission tomography, or the cerebral angiogram, lumbar puncture, or the biopsy. Again, these depend on what the patient requires for their condition. Management. The management of brain and spinal cord tumors depends on number 1, size, number 2, type, number 3, grade of the tumor. Also, we have to concentrate on to what extent is the damage? Is there metastasis? How much metastasis? Possible side effects, maybe the patient's overall health condition, do they have any comorbid conditions? Are they at risk to getting opportunistic infections? All are important management questions that you have to focus on. We have the palliative care, which is the first type of care that we offer patients. What does it focus on? It focuses on reducing the symptoms or improving the patient's general health. This is what palliative means. What can you give? You can give them painkillers, you can prescribe corticosteroids, anticonvulsants, physiotherapy, and also psychological counseling. Next, we can also ask the patients to check if, for example, let's say, what kind of grade do they have? Do they have a low-grade tumor or do they have a high-grade tumor? If surgery is required, what kind of surgery is going to be best for the patient? For example, we have a craniotomy, we have the cortical mapping, we have the image-guided surgeries. If the surgery needs radiation or chemotherapy, again, that will be advised. And of course, we also have this other sort of therapy. It's called the alternating electric field therapy. Again, depends on the patient and what kind of method would be best at improving their problems and improving their general health. Thank you very much. That was the end of my presentation for today.
Thank you so much, doctor.
No
Go ahead.
problem.
Hello, Sonalis. Welcome.
Well, it's good.
Hey, could you please introduce yourself?
Okay. My name is Johnson Senatus, and I'm from Dominican Republic. So now I'm living in Russia and do neurosurgery, and it's all.
Hey, you're in the right spot.
Welcome.
Yeah, Mila, as you know, is not far from you in Russia right now, correct?
Yeah,
Yeah, you're still in Russia, correct, Justinata?
yeah, it's correct. Yeah.
Okay, I
Thank you,
had one.
Myra. Thank you, Myra, for the presentation.
No
Good.
problem. No problem. I hope you have now like been able to like revise important things of the three different topics I talked about.
Okay.
Yeah,
When
just the
my
base.
computer is good, when my computer is good, I will press it accept.
Sure, no problem.
Yeah.
Okay, one remark someone said, I didn't want to interrupt you. They asked, okay, Achilles, Achilles, are you there? Do you want to ask the question directly or do you want me to ask it? It's not really a question. Okay, what about parasites, fungal infection, and Neisseria meningitis in encephalitis? And they think that's important.
All
Okay,
right, thank you so much, Dr. Achille. I'm not sure if I'm pronouncing your name correctly, but that's a very important question. And yes, Neisseria meningitis is very important. Also, see, like encephalitis is a general disease. There are 197 countries, if I'm not mistaken, according to Google. So, for example, like Neisseria meningitis, if I'm not mistaken, mostly patients in Africa they're affected with it. So see, different places have different geographical locations, different geographical conditions, different sorts of things which can like aggravate the disease. So yes, parasitic fungal infections are very important. Again, you have to study the history of the patient. If you do not know the history, you will not reach your diagnosis. I hope I've answered your question.
Yes, yes. But can I answer another question?
sure.
Because yes, because during the presentation, is it possible to about encephalitis talk about trauma? Is it possible? Because in case of trauma, when you have a edema when you have an edema, is it possible to talk about encephalitis?
You mean in your differential diagnosis?
Yes, yes, differential
Yes,
diagnosis.
yes.
Okay,
It's
okay.
very important to come up with not just one differential diagnosis. For example, like my professor, he always stresses that if you come up with at least a minimum of 2 or 3 diagnoses, like the teachers, they can see that, okay, you know your knowledge, like you know exactly what you're studying. One differential diagnosis, it's very rare. You have to think about different causes. Do you get what I mean?
Yes, yes, I get.
Yes.
Achilles, where are you from?
Coming from Cameroon.
Yeah,
Cameroon.
yeah, welcome,
Cameroon.
Cameron.
Yes,
That's
Cameroon.
excellent, excellent,
Yes, doctor.
and welcome.
Thank you, doctor.
Okay, very good. I appreciate Milo taking the time to organize this and to get it
John,
together. Well, go ahead, Sonata. Yeah, anything? Go ahead.
yeah, I want to say something.
Mm-hmm.
So, about the publication of Spanish Society of Parkinson, they say on the deck, the ultimate cause of Parkinson is not known.
Yeah, that's true.
Yeah,
That's
it's
good. You've done your
considered. Yeah, it's considered that it could be due to a combination of genetics, environmental factors, and more. You understand?
Yeah, familial history. Again, it can be,
Mm.
you're perfectly correct. It can also happen because of genetics, familial inheritance. It all depends on like genes as well. So yeah, that's correct.
Mhm.
Okay, very good. Mila, what neurosurgery basic topic are you going to have? I guess in 2 weeks. So when's your next program?
I think maybe next week I'll like try to do something. I would actually really want to talk about one of my favorite syndromes. I'm going to go into depth with it, hopefully maybe either next week or next week. Cauda equina syndrome. So like I'd want to like talk a lot about it, but I will let you know maybe if it's ready like in 2 weeks. Let's see.
First time I've ever heard someone say Cauda-Equina syndrome is my favorite. I've never heard that before. That's great.
I think I enjoy it. Like I have my notes stuck on my bed, like everything about it. So I don't know.
Oh, that's nice. Okay. Well, okay, I'll end this and stick around, please. Everybody, thanks for coming. Stick around.
Thank you, everyone.
Thank you.
Bye.